This video is on acute delirium and agitation. It covers the risk factors, treatment options, including antipsychotics and benzodiazepines, as well as the prevention options. The definition of delirium is listed here, and there are many synonyms that may be used. The DSM-5 criteria include a disturbance in attention. So this shift in attention is important in the diagnosis of delirium. The information in these slides will mirror that of the American Association for Emergency Psychiatry guidelines. There are numerous different guidelines, and many of them are not in agreement. Altered mental status accounts for 1 in every 50 A&E visits, and even more than that in the elderly. Medications, along with disease states, are very common causes. Delirium is also a strong predictor of in-hospital mortality. Delirium can be either hyperactive, or also more difficult to notice is that it can be hypoactive, as shown in this graphic here on the bottom left, borrowed from the European Delirium Association. You have normal function here. You have agitation being up here. So delirium can be anywhere between these two ranges, with hyperactive being up here and hypoactive being down here. You can't test for delirium in a patient who's in a coma or just heavily non-responsive. In general, symptomatic pharmacologic treatment is not used in hypoactive delirium. Delirium develops over a short period of time, usually hours to days, and tends to fluctuate during the course of the day, whereas dementia is more chronic and consistent in nature. It is fairly common for patients with dementia to develop delirium. Many risk factors for delirium are what you would expect, such as old age and multiple medications. Sensory deprivation includes items such as hearing or visual impairment, immobility, or malnutrition. This slide just shows how complex the pathophysiology of delirium can be. This will not be on the test as it is very overwhelming, and you could do an entire lecture just on the pathophysiology. As you can see, some pathophysiology relates to the dopamine, others is the cholinergic activity, serotonin. Really, it's very complex, so we are going to skip for the purpose of this lecture. A challenging situation when treating these patients is that if you don't treat the patient soon enough, then they may cause harm to the hospital staff or themselves, particularly in hyperactive delirium. On the other hand, if you treat them too early, it will make a comprehensive psychiatric evaluation and history extremely difficult, as they will be heavily sedated. As stated in the guidelines, it is important to note a few points. Firstly, medications should only be used when absolutely necessary. Not all delirium patients require pharmacologic sedation. Non-pharmacologic treatment, excluding physical restraint, should generally be attempted first. Patients should be calmed with the medications, not to the point where they are deeply sleeping. Also, if it is possible, it is preferred that patients take any medications via oral route instead of parenteral. Treatment for acute agitation or delirium is based on the underlying cause. If an infection is causing the delirium, then antibiotics would be given. If hypoglycemia is contributing, then glucose would be given. If Wernicke's encephalopathy, then thiamine would be given. If an overdose, then the appropriate antidote should be given, or if there is an electrolyte abnormality, that should be corrected as well, and so forth. It is quite challenging to determine the cause of delirium in a patient, so generally a rather wide array of labs are often ordered to help rule out and identify some potential causes. There are also several supporting measures that should be done in addition to providing pharmacotherapy. These are aimed to help reorient the patient back to normal living situation. Vitamin C is a mnemonic device to help remember potential common causes of delirium, such as infectious causes or inflammatory causes, certain electrolyte abnormalities, and different medicines. There are dozens of drugs that can precipitate delirium, with some of the more common causes underlined on this slide. If the agitated patient is not satisfactorily responsive to the non-pharmacological measures, then there are basically three possible treatment options: first or second generation antipsychotics, benzodiazepines, or a combination of those two. Lower doses are often used in the elderly, and you can redose midazolam every 3 to 5 minutes or lorazepam every 10 to 20 minutes as needed. Alcohol withdrawal and overdoses of particular drugs may require larger cumulative doses. Also, if the patient develops seizures, then the benzodiazepine would be preferred. Haloperidol and droperidol are the most commonly used agents. This is despite the Society of Critical Care Medicine recommending against the use of haloperidol in these patients. Adverse effects to be aware of including QTc, interval prolongation, which is more dangerous with IV administration, as well as extrapyramidal side effects. Combination therapy with benzodiazepines may reduce the adverse effects associated with the first-gen antipsychotics. Often, the second-generation agents are preferred over these first-line agents. Be sure to monitor QTc interval, especially in patients with cardiac abnormalities, electrolyte imbalances, or hypothyroidism. 1 milligram PO haloperidol is equivalent to about 0.6 milligrams of haloperidol given IV. You really get maximum dopamine blockade with about 4 milligrams IV, so I often don't go above that, because then you just mostly are increasing the risk of developing EPS symptoms like dystonias, akathisias, Parkinsonism, bradykinesia, or tardive dyskinesia. The second-generation antipsychotics may be considered as first-line agents as well, pending the suspected cause of the acute agitation. They tend to have less dystonia and akathisia, whereas aripiprazole is possibly less efficacious as it is only a partial antagonist, and quetiapine causes more orthostatic hypotension, so it is often not the preferred selection as well, since patients in the A&E are often volume depleted. The manufacturer does recommend against the combination of olanzapine and benzodiazepines due to increased risk of respiratory depression. Ketamine has also recently been researched for use in delirium or acute agitation. It's not currently in any guidelines. The doses used in all these studies is about 5 milligrams per kilogram, usually always given IM, often even before they get to the emergency department, in the ambulance. It does have the fastest onset of the agents available, roughly averaging about 5 minutes before it starts working. And it also does have a short duration of less than 20 minutes, so you can do your psychiatric evaluation quicker, because your benzodiazepines, they can work easily for 9 or more hours. The problem with ketamine, though, is that it did cause more complications and a lot more intubations and ICU visits for patients receiving ketamine versus those receiving haloperidol. So because of this, because of these more complications and intubations, ketamine is most likely never going to be used for these patients, particularly in Hong Kong. So haloperidol is the most commonly used treatment in Hong Kong for undifferentiated acute agitation, used almost 50% of the time, even though droperidol may require less dosing. Although haloperidol is currently more commonly used, atypical antipsychotics are still a very viable option, as they tend to have less adverse effects, with ziprasidone being one of the best tolerated options. A meta-analysis has shown that typical and atypical antipsychotics have similar efficacy rates. Combination therapy with an antipsychotic and a benzodiazepine is less common in Hong Kong than it is internationally. However, the most common combination used here in Hong Kong is midazolam with haloperidol. Combination therapy is often recommended as lower doses of each of the two agents can be used, and as many of the adverse effects of these medications are dose-related, the incidence of adverse effects may be lower, in addition to combination therapy being more effective and having a faster onset than either agent used alone. The times shown here vary dramatically from study to study. In this study, haloperidol was 28 minutes was the average time to onset. But in another study, haloperidol showed an onset of roughly 17 minutes. That may seem pretty fast to some of you, but whenever someone's thrashing around and it can get quite dangerous, that can really seem like actually a really long time. That's why people looked into see if ketamine, because it works quicker, could it be used in this situation. But it led to worse patient outcomes. And also, if you look at lorazepam on here, this study showed that it took 32 minutes to sedation, but there's other studies showing that it can work in just as quick as 3 minutes. This slide is one of the most important slides from this presentation to be familiar with. It is directly from the American Association of Emergency Psychiatry. Basically, if you have an acute agitation case of unknown cause or a psychiatric disorder, then a second-generation antipsychotic is preferred. If the acute agitation is due to alcohol, benzodiazepine withdrawal, or stimulant usage, then a benzodiazepine may be preferred. And lastly, if you have acute agitation due to a CNS depressant, then a typical antipsychotic would be preferred. When referring to combination therapy, it is always an antipsychotic with a benzodiazepine. This slide is roughly the same as the previous, just a bit more simplified and easy to read. Also worth noting is that in the acute agitation due to alcohol withdrawal, clonidine may be helpful in reducing the sympathetic overdrive of alcohol or benzodiazepine withdrawal, thereby easing delirium and agitation. There are many possible causes for delirium, and they should be identified and treated as soon as possible. Many of the treatments for these causes are obvious. Also, if you have a patient with an idiopathic psychosis, patients with hallucinations or delusional thinking or paranoia, then antipsychotics would be preferred over benzodiazepines. Delirium or acute agitation is not just a problem presenting to the A&E, it is also quite common in critically ill patients, particularly those who are critically ill for longer periods of time. There are many risk factors that can increase the likelihood of developing delirium during an ICU stay, as listed here. This graphic shows why it is important to limit doses and durations of benzodiazepines in patients, as it can dramatically increase the risk of developing delirium. In addition to benzodiazepines, also, age significantly increases the risk of delirium in ICU patients. This shows why it is even more important to try to avoid benzodiazepines in the elderly. And so why do we so dramatically want to avoid causing delirium in patients? Because patients who develop delirium during an ICU stay have a much higher mortality rate, as shown in this graphic. So avoiding benzos helps us avoid delirium, helps us reduce mortality rates. The CAM ICU assessment can be used in mildly sedated and alert patients to determine if they have developed delirium. It is a very commonly used delirium diagnosis tool in Hong Kong. It is a useful tool that simply tells you, yes, the patient has delirium, or no, they do not. It does not indicate the severity of the delirium. The RASS score is a commonly used agitation and sedation score used in Hong Kong emergency departments and ICUs. The goal is generally to keep patients between -2 and +2, or even better would be +1 to -1. There are many things that a pharmacist can do to aid in the management of delirium, starting with carrying out a medication review and ensuring appropriate pain and sedation therapy while minimizing any modifiable risk factors. Assessing a patient that is critically ill routinely is important to identify, treat, and minimize delirium as soon as possible. It is important to restore sleep cycles, involve familiar people and family and friends, and to provide sensory aids used at home to help them become more oriented sooner. Antipsychotic therapy, if necessary, should be given by mouth if possible, and low doses to calm the patient and not induce sleep in the patient. Nutrition, oxygen saturations, avoiding infectious procedures like catheterization, and fluid status should all be addressed within 24 hours of admission by a multidisciplinary team. Many agents have been attempted in the prevention of delirium, but with very little success. Cholinesterase inhibitors, often used in Alzheimer's disease, low doses of antipsychotics, gabapentin, and analgesics are not to be used in delirium prevention, as the data is not significant enough to warrant usage. One medication that may be considered in patients at high risk for delirium would be melatonin, due to its safe adverse effect profile. Several studies, as shown here, have proven benefit of this practice. So patient case 1. A 33-year-old muscular male is exhibiting very violent behavior. The treating physician asks, which of the following agents has the fastest onset? Is it lorazepam, midazolam? Is it ziprasidone, olanzapine, or there is no clear difference in time of onset between these agents? So answer E is correct. Some believe benzodiazepines such as midazolam may be faster, but the literature to support that is not strong. Patient case number 2. A patient with acute agitation was given 10 milligrams of haloperidol for calming effect. The patient now has mental status change, rigidity, fever, and dysautonomia. The physician tells you he believes the patient has neuroleptic malignant syndrome. Which of the following agents should not be used to treat a patient with neuroleptic malignant syndrome? Is it bromocriptine, dantrolene, amantadine, or metoclopramide? D is the correct answer. All others are possible treatment options. Some take-home points are as follows. In a patient with psychosis or a psychiatric history, antipsychotics should be recommended over benzodiazepines. Many modifiable risk factors can be addressed to minimize the risk of delirium, and as a pharmacist, it is more important for you to focus on drugs like benzodiazepines that can increase risk of delirium. Melatonin may be recommended for the prevention of delirium in high-risk patients due to its safety profile, but overall the guidelines currently do not recommend any pharmacotherapy for delirium prevention. Combination therapy is safe and beneficial, so may be recommended. And lastly, you should review the slides regarding adverse effects on these medications from last semester's lecture. These are the references utilized. Thank you for your time and attention.